Well, good afternoon, everybody, and welcome back. And thank you for joining us for our afternoon session of PrimaryCare22. My name is not Sherry Erickson. My name is Shawn Martin. I'm glad to be back again. I'm the CEO of the American Academy of Family Physicians. Ms. Erickson was not able to join us today because of a family issue, but I am going to do my best with our two panelists to lead this conversation around innovations in the public health programs. And this afternoon is really the innovation section of our agenda. We're going to have three back-to-back panels about innovation, starting with the public programs and then moving to the community health centers, and then talking about innovations inside the commercial and employer market. And at the conclusion of all that, we're excited to have Keena Fong, who's going to wrap up and kind of give us a call to action for where we may go at the conclusion of our program. But I am honored to be here today with Greg Gierer, who is the Vice President of Policy and Research at the Better Medicare Alliance, and also Dr. Kameron Matthews, who is the Chief Health Officer of Cityblock Health. Thank you both for being here. And when I pose the first question, I think it would be most appropriate if you gave a quick synopsis of your organizations that you represent, so that people can better understand those things. So we're going to talk a little bit today about the successes and barriers of innovation inside the public programs. Obviously, Cityblock has been heavily engaged inside the Medicaid space, but not solely. You venture over into Medicare a little bit as well, and we're going to talk about that. And then, of course, the Better Medicare Alliance is a very well-known advocacy coalition that really has focused on the Medicare Advantage space. But Greg, I spoke to him earlier. Greg has been influential in the Medicare space for a long time throughout his career. So we're going to tap his expertise a little bit on the fee-for-service side of Medicare as well today, and about how innovations are taking place there. So let's jump in if you guys are ready. And Kameron, I'll just come to you first. So can you share a little bit with us about the successes you've seen related to innovation in the Medicaid program, and then also where you think there's room for innovation as you guys start to think about the kind of carryover between Medicaid and Medicare with your population?
Yeah, thank you so much. Really honored to be here to share a little bit about really the journey of Cityblock Health. We've had 5 years, I think, of really transformation. That's how we like to think of it, in really trying to make sure that we're bringing attention to these communities of marginalized people in Medicaid, as well as dual eligible populations. And the concept is really to find value, to improve outcomes, and to accept the risk, yes, in order to make the change that is necessary for their well-being, for their general health. So for us, in accepting risk, we're able to really step outside of the typical, at least what I'll describe personally from my experiences in the FQHC world, very restrictive sort of space of really focus on productivity and process, even as far as metrics, and really paying attention more to the outcomes that our members are facing. And doing so in as integrated a way as possible. Each of our markets are very different. We're located across 5 markets at this time. And the ability for us to really understand the community, first and foremost, to engage with the community that we're with, and then build the programming around their needs is fundamental to that. So our ability outside of the fee-for-service space to integrate behavioral health in really unprecedented ways, treating severe mental illness, substance use disorder, and also addressing social needs by thinking, assessing and addressing food insecurity, homelessness, transportation. These are just the day-to-day accomplishments, really, that our care teams are able to provide through a very interdisciplinary care team that otherwise the management of which in a fee-for-service structure is a bit unruly. So we've been successful, and I think the translation, as you asked, to the Medicaid and Medicare space, I think is quite has been quite easy. We take on a significant amount of responsibility as far as care management, in addition to other responsibilities under those contracts, and we've been successful. We're not the only ones in this space, but I do think we really are at the forefront of having an understanding of really the community engagements that's required to address health equity, particularly with these populations, and are doing so really at I think impressive outcomes.
Well, thank you so much. And Greg, of course, I mean, Medicare and Medicare Advantage, I mean, dating all the way back to the prescription drug bill, have been, on a pretty healthy trajectory about driving innovation in payment and care delivery. And so a similar question, what are just some of the, successes you've seen and how innovation is driving better care in the Medicare program?
Thank you, Shawn. Great to be here today and be part of this panel with Dr. Matthews and talk about this, really important issue. Just a little bit of background. I know you guys are probably familiar with BMA, but we're a research and advocacy organization that's focused on supporting Medicare Advantage, and we have over 170 allied organizations, including broad spectrum of organizations from across the healthcare system, including physician organizations, many of which who are here today and are members of BMA, as well as 600,000 beneficiary advocates as well. And our mission is really to focus on strengthening and protecting the Medicare Advantage program so that it can continue to serve the 28 million beneficiaries who are enrolled and future enrollees. And as Shawn mentioned, the program has been growing over the years on a pretty increased trajectory. It's popular, and it's leading to better health outcomes. And really, primary care is central to the Medicare Advantage model. The Medicare Advantage model is about primary care, prevention, early detection, and coordinated care. And that's why primary care is central to really the Medicare Advantage model, because it works and it provides the coordinated care that beneficiaries need, particularly when you're thinking about the Medicare population and the Medicare Advantage population. Beneficiaries with chronic conditions, multiple chronic conditions, they need that access to primary care. And when you're talking about successes, I think you have to look at success as well as challenges. So we're asking a lot from primary care physicians, but we also know that there's well-documented challenges as well. Underfunding, underinvestment in primary care, the way the healthcare system is oriented. There's just less funding for primary care. There's also workforce issues, particularly in underserved areas. So that's really been, the focus. For us, there's promising interventions in primary health care and primary care, particularly in the Medicare space, and we can definitely talk about those. A number under the auspices of CMMI, which have shown some early promise, but in Medicare Advantage space as well. And I think a key here is really value-based payment, and I think there's just widespread recognition that fee-for-service doesn't work for the healthcare system overall, and it really is ill-suited to support primary care and the importance of coordinating care for those with chronic conditions and primary care. As far as success in the Medicare Advantage space, there's been a number of success. I mean, if you look between Medicare Advantage and fee-for-service, Medicare Advantage beneficiaries are just much more likely to receive preventive care services, including, life-saving screenings. Medicare Advantage spends more on primary care services than under fee-for-service, 30% more according to recent research. And those investments translate into better access and better outcomes when you're looking at fewer hospitalizations, fewer emergency room visits, fewer preventable hospitalizations. That really shows that the Medicare Advantage model is delivering, effective, comprehensive primary care. And just one other point is also just the importance, particularly when you're talking about this patient population, which has chronic conditions, multiple chronic conditions, having a usual source of care, which is a primary care physician, to coordinate that care, make sure that the patient is adherent to their medical treatments, that they're getting that continuous and coordinated care is so important. And really the Medicare Advantage model really fits well within that framework. So those are a couple of the successes. And I think, there's a demonstrated track record there. And I think for some of the other efforts underway, I think there's some promising results too, but we could talk more about kind of what are some of the challenges there.
Yeah. Well, thank you both for that. That was a good warm up. So now I think we can dig into a harder question and some of the challenges that you're facing or you're seeing and witnessing. Everybody agrees that the payment structure needs to be changed. That the payment structure is kind of incongruent with the goals that we want to have. But what are some of the other barriers you're seeing as far as innovating within the Medicare and Medicaid program that are beyond money, but barriers that are being put up that are preventing you from truly innovating?
Yeah, I think because we're across multiple markets and because really our ability to innovate is really encapsulated with our ability to communicate within our care team, but also with our partners throughout the communities that we serve. The barriers that we face are really around data and interoperability. I would definitely make sure to highlight that, as much as we are able to put a lot of our resources in building out our own kind of proprietary system and how we're managing our own patients, our care teams, whether it's primary care, behavioral health, we still need to have that information source so that we can truly treat our members as holistically as possible. And without really that interoperability to be able to understand and to reduce duplication and to be able to communicate best with other care teams, that's one of the biggest difficulties. And particularly in cities with large academic medical centers, multiple FQHCs that we're working with, even private practices, you can imagine the amount of difficulty it takes, the resources it takes to really be able to help those members no matter where they are being served. And so I see that as one of the difficulties, that we really don't have a forcing function yet to get us to the point of truly being as person-centered as possible, as opposed to health system centered. So that rises to the top of my list.
Yeah, agree wholeheartedly on some of the barriers that Dr. Matthews mentioned. Data, I think, is a key one. So definitely want to second that. Not only just around kind of electronic medical record and interoperability, but also just sort of data collection on the patient population as well. I think that's just so important when you're thinking about these, whole person, patient-centered models. You really need to have that accurate and complete, diagnoses, so that informs kind of the care management and your risk stratification and really taking care of the healthcare needs. So I think the data is kind of, in those two areas. Payment, I think, is a big barrier. We're moving away from fee-for-service to sort of like a continuum of different models. I think in the Medicare Advantage space, there was a report by LAN, the Learning Action Network, that really showed that Medicare Advantage is leading the way towards value-based payment, but we're not all the way there yet either. I think that those efforts need to be accelerated. But which gets to the third point, is that they also have to be kind of tailored to the community, and not, everyone is ready to take on these full risk arrangements for a variety of reasons. And so kind of avoiding sort of like a, one size fits all approach. They need to be really tailored to the patient population, to the neighborhood, and to the physician workforce, to really be delivering kind of the comprehensive patient-centered primary care that is just, so important for Medicare beneficiaries.
Well, great. I want to ask some questions about CMMI, and I'm going to start with you, Greg, because I think everybody has always appreciated the first M in CMMI, which is Medicare, but we're going to get to the second M about innovation. But CMMI, of course, since being created in 2010 and ramping up, has devoted a lot of effort to innovation inside the Medicare program, broadly speaking. And I'm wondering, we heard from Elizabeth Fowler earlier in the program, but I'm just wondering, from your perspective, kind of being in this space throughout that journey of innovation, just some reflections on how CMMI has handled innovation in Medicare, where you think they should go, and general observations about the work to date.
Yes, I mean, so much important work coming out of CMMI, and particularly under the new leadership. I guess it's been, it's 12 years now, right, since CMMI, and dozens of models, are under their purview. several related directly to primary care. I'm sure Liz went through a lot of the details there as far as the early results, but some of the early results are very promising. But I think with a lot of these models and a lot of the work is that very few health interventions kind of deliver cost reductions or quality improvements in year one, year two. These are things that they take investments, they take time, and so you may not see those results, over a calendar year. But if you look at it over time, we know these interventions work, and that's exactly the work that CMMI is doing in testing and evaluating these models. We strongly support the work of CMMI and their strategy refresh around embedding health equity in these models. From a Medicare Advantage perspective, we've been very focused on the VBID model, which is the only Medicare Advantage, model currently under CMMI's, purview, and so is not directly related to primary care, but in many respects it is, because it's about really incorporating, the concepts of value-based insurance design into the Medicare Advantage space. And so VBID is not a new concept, but it is fairly new for Medicare Advantage. It started, I believe, in 2018, and it's really about addressing the barriers to high-value care and eliminating and reducing, whether they're financial or otherwise, to ensure that beneficiaries are getting access to high-value, high-quality care, high-quality primary care. And I think that's been a program too, where it's like initially interest started off slow as far as plan participation, but now has been on an upswing. Over 3.2 million people are now enrolled in the Medicare Advantage VBID. And it's really about realigning both payment and benefit design to encourage high-value care, primary care, preventive care, and discouraging, low-value care. And that's really where the whole healthcare system needs to go. And CMMI is really spearheading these efforts when you talk about value-based payment and delivery reform, but also putting their own policy principles around it, around health equity, around access and affordability, and something that certainly BMA applauds and encourages.
Yeah, Greg, let's stick with Medicare just a second if we can. So about 65 million beneficiaries. Of course, the program continues to experience tremendous growth because of retiring generations. But I think another data point that often gets lost is just and one that should be celebrated, is the growth of individuals that are living past the age of 80. So, life expectancy for many individuals is stretching into territory that is unfamiliar, for us as a country as a whole. Other countries in the world have experienced this. But as the program evolves, a lot of people have made the observation the program wasn't designed for people to live, that long. But as the program evolves and we have just a kind of growing, aging population, what does the program need to do to, truly meet the healthcare needs in the most, efficient manner possible moving forward? And what role? Obviously, I'm leading you that primary care is going to play a big role in that. I hope you picked up on that. But kind of how can primary care help the program achieve those goals?
Is this for Dr. Matthews?
Yeah, that's
for me?
for you.
Okay, yeah, no, great question, Shawn. I think, the aging population, and this is really a testament to some of the strength of the healthcare systems, that people are living longer and healthier lives into their well past their retirement years, and that's a great development. But how do we kind of ensure that the systems and the care are there to support? And one of the innovations that we've seen in the primary care space and the Medicare Advantage space is really delivering care in the home. Has been a big focus, I think, for Medicare Advantage and Medicare overall. In the Medicare Advantage space, it's going into the beneficiary's home, using these health risk assessments, where a practitioner will come into the home and really provide a comprehensive screening. There is this also in traditional Medicare, it's the wellness visit, but this is much more comprehensive, and really it's clinical visit as well. And it's screening for health risk factors, it's screening for social risk factors, and how to tailor the intervention so that you're caring for the whole person's healthcare needs in a way that is comprehensive, but also tailored to the specific needs of the patient population. And then from these HRAs, their follow-up care with your primary care provider, to your specialist if needed. And, these have been around for over 10 years. These in-home HRAs, they've been increasing research about the effectiveness, and they are effective. They reduce hospitalizations. They reduce the need for emergency room visits. And it's really about coordinating the care for the patient population and making sure that if they have diabetes, they're getting their diabetes medications, that they're compliant with their prescriptions, that their house is safe, that there's not risk for falls, that the beneficiary has access to transportation to get to the doctor. And so we're really excited about those innovations there, really delivering that patient-centered care in the home.
Yeah, great. So let's go to the other end. Medicaid, 85 million, approximately individuals rely upon the Medicaid program for their health care now. CMMI, to their credit, has really started to turn their attention towards innovation within the Medicaid program, which I'm sure you celebrate with us. So let's talk a little bit about what CMMI could and should focus on around innovation in the Medicaid program, and then I want to follow. You can just follow up. I'll give you a follow-up question, because the services in Medicaid are different than Medicare. It's not a homogenous patient population like in the Medicare program. So almost half of all births in the country are on Medicaid. Large number of children receive their health care from the Medicaid program. So innovation obviously is going to look different there, and would love your thoughts on where we go.
Yeah, I think where we have found the most success is stepping outside of really the traditional box of expecting our members to come into our clinics to speak with our very traditional sort of provider care team alone, but instead doing exactly as Greg described. We instead are sending our care teams into the homes. We're sending our providers, our nurse practitioners, our community health workers. The concept of who is on our care team and who's really assisting our patients connect the dots and navigate through the health system is something that I think we need to do better at measuring, as far as how it's impacting their well-being, how it's impacting their healthcare outcomes, how it's preventing ED utilization, inpatient admissions, even particularly when we're talking from a mental health standpoint. So I firmly believe that the strength behind really the broader concept of our care team is something that needs to be further explored and incentivized more than anything. You mentioned kind of maternity care. We're very proud to be exploring our own interventions and really thinking about our doula program and how we're working with the delivering providers and the prenatal providers. Sometimes they're not necessarily the same for these communities. Sometimes it's really about focusing on how we're meeting our patients where they are at a time, making sure we're meeting their needs, and it's not always going to be within our walls. It's not always going to be on one of our screens. Sometimes we need to meet them in the community park. Sometimes we're sitting with them on a bench. This is something that our community health workers, our doulas, are doing day in and day out. And to make that impact across a full population, we'll need to recognize that it is not going to look like a traditional workforce. It needs to include concepts that have broader approaches to social needs, social drivers of health, and really be more responsive as far as access, 24/7 services, evenings, weekends. These, of course, are something that we have throughout healthcare, but it's almost seemingly as if it's an inconvenience that we're checking off a box by having these extra hours of care, as opposed to assuming that should be the standard. So incentivizing that we're putting the members' needs first, again, is what I think needs to be promoted.
Yeah, so one of the challenges I assume you face, unlike Medicare has a central governing agency. Medicaid has 51, 54, 55 governing agencies. So how How is the kind of dual responsibility of the federal and state governments impacting your ability to truly be innovative? Because CMMI could support you,
Yeah.
and a state might not. And how's that? What are you learning?
It's hard. For those that don't know, we, like I said earlier, we're in 5 markets currently: New York, Connecticut, Massachusetts, DC, and North Carolina. And as I'm sure many of you are already thinking, just the difference between those bodies alone, exactly, let alone where we're looking to go this year, next year, as far as additional markets. It's difficult, but it's not unachievable. When again, we're really thinking about how we're able to provide that integrated interdisciplinary care. Yes, there are different sets of requirements that we need to meet, different data components that we need to report out on. But across the board, we try to find, of course, that basic minimum and keep in mind that it's actually our outcomes and not so much the process that we're trying to prioritize. So I'm not saying that we have the answers yet, but I think we've made amazing progress again with our own internal technology, with the partners that we make, the payers that we work with, as well as the community organizations, the network providers that we have in the state. We've been able to make very good inroads. Variability between markets, yes, is going to persist, but at least from a care model standpoint, we are deploying and we will continue to innovate by really thinking about, again, our care teams and what our members need more than anything. Now, the variation of requirements, regulatory requirements from state to state, even outside of Medicaid, does impact us a bit. And so our staffing needs are different in every state. Our reporting requirements, interoperability with different EHRs in each state is different. It's a lot to manage, but I think the commonalities are actually with the clinical care that we're providing every day, and so we're able to traverse it.
Yeah. So both of you have mentioned care being provided outside of, I think you both used the word, the traditional care setting. So not just in the home, but just moving away from the patient going to the care setting or the physician and actually the care team or physician going to the patient. And I'm struck by the fact that almost every panel we've had here has alluded to this kind of transformation. So is one of the principal innovations inside primary care really breaking down the legacy concept of where care is provided, and how do you see that in your respective programs as we move forward? That's a shift, right? Like you go to the doctor. I mean, that's just the way it is. You take off work and you go to the doctor. So talk a little bit about how you see that playing out over the next, I think, 5 years.
Hands down, that needs to be debunked as the only path forward. We're very proud to have a strong and vibrant ED at home program. So we have our emergency physicians actually on an iPad. Our EMTs are going into the home after we've screened and actually made an appropriate assessment that this can be handled in the home. We have that sort of hybrid visit where we have someone there actually performing the evaluation. There's someone performing the diagnosis on the other end of the screen. At times, we'll also send a nurse practitioner in as well too for stabilization, particularly from a behavioral health standpoint. This is impactful in so many ways that it's not disruptive enough that we're calling a 911. We're potentially traumatizing a member in a different way by expecting them again to go into an ivory tower sort of situation. So as much as we can perform, especially in that acute setting in the home, we're very dedicated to, and we're even building our pods, our care teams geographically such that we can make sure we're also facilitating primary care in that way as well too. Mm-hmm. So the primary care provider either on a screen or going into the home along with an MA or an EMT going into the home, it actually allows us to engage with them in a much different dynamic as far as just our communication, the trust that we're able to earn by learning more about them, about their family, about their environment. I think it changes the dynamic to exactly what primary care is supposed to be, but yet we have the barriers of our clinic walls, unfortunately, that prevents it.
Yeah. Great.
Yeah, I agree completely. We're very encouraged, I think, by a lot of the innovations we're seeing in primary care. I think there always is going to be the office visit, and that's not going to go away. But I think there's just so much potential to expand access as well, whether that's through the home, whether it's through use of new technology. Obviously, telehealth, the explosion of telehealth during the pandemic. I think patients really benefit from that access and the convenience of that. So I think that's using that technology is going to be important going forward as well. And then quality of care, I think, is a big piece of this too, and kind of thinking about new models where it's deeper patient access, 24/7 access. So it's not just a discrete office visit, but it's continuous through the continuum of care. And so some of those are some of the exciting interventions that we've been following closely that have been part of the MA model for some time. And I think we really look at innovative ways to expand access to primary care. It's just so crucial for people's health and healthcare.
So another thing you both alluded to was the importance of care that's unrelated to kind of the traditional physician-patient relationship. So housing security, food security. Greg spoke about making sure the home was safe against falls and other types of things. But can you speak a little bit about how the two programs, Medicare and Medicaid, are both investing in, housing and food security, things that help people be healthy that really have nothing to do with, the care team themselves, but are being facilitated by the care team?
Yeah, I mean, we see it in our model at least as an innate part of how we're actually engaging with our members, earning their trust, and honestly addressing their priorities. It's really I think the medical establishment that is unfortunately kind of creating these barriers of prioritizing sort of clinical diagnosis and clinical work, when instead it should really be about establishing those relationships and understanding what their concerns are. So our community health partners, as we call them, are fully prepared to assess and address any number of needs. They are, in fact, I was with a good group of them I think it was yesterday. We have a mobile van that we park in wards 7 and 8 here in DC, and our community health partners actually ask our members to come to the van. Just come and say hi. Just come and have a conversation. Oh, let's actually also schedule you. The provider's not here today, but we're gonna get them on a camera. And just come sit in the van, sit with the staff, but your provider will be on a screen, and it'll be a great conversation. And these sort of connections to really think about social interaction, about, again, maintaining that trust. Just the one patient I saw yesterday, just her willingness to have a conversation with us, and how she actually talked about some of the other providers in her life really, I think, drove the point home that regardless of whether it's something as tangible as providing food from the food bank, although they were right next door, because they show up when we show up as well too, or getting someone a home. Sometimes those social needs are just those soft conversations, those soft interactions that this patient, in fact, really prioritized and otherwise would not let us continue on and have the conversation about her behavioral health needs without that sort of engagement. So I think the difficult part is this is hard to measure.
Right.
And it's hard to
It's immeasurable.
but it is immeasurable. That's exactly it. So I think in our model, because we're not forced again to think about the productivity and the fee for service and how we're billing for this, but we are there to take care of that member. I could sit there for as much as I needed to with her and engage with her and have other staff come, and it's going to pay dividends. Exactly, it's immeasurable.
Yeah, absolutely. I think it's really about meeting patients, where they are, but then also at the same time, reducing barriers to care. And so I think there's been tremendous interest really in looking not just at the health, but these social risk factors as well. And so, in the Medicare Advantage space, one way Medicare Advantage, works to address those social needs is through, one, investments in social determinants of health, but also second, the offering of these enhanced benefits that are available through Medicare Advantage. Increasingly, thanks to regulatory and legislative flexibility, increasingly on these social risk factors, non-health factors such as nutrition and transportation, in-home supports, tailoring those benefits to those with chronic conditions. And I think what we have seen is really a proliferation of increases in these supplemental benefit offerings. We have good early results from these interventions. What we don't have is kind of industry-wide data on what is the utilization of these benefits, what's been the uptake, what's been the return on investment or impact on health outcomes. And I think there are a couple factors at play there. One just being these are relatively new, this flexibility is relatively new. And as I mentioned earlier, it takes time to kind of evaluate these things. These are things that don't come up in 1 year or 2 year, but these are long-term investments in people's health. And we do know they work, but kind of future policy consideration is kind of thinking about these more critically and how these partnerships work. And so a number of these partnerships are new. Medicare Advantage partnering with meal delivery. These are not contracting with hospitals and physicians. These are community benefit organizations at the local level. And what are some of the challenges there? What's worked well? What examples that have worked well could be applied more broadly? Where is there kind of friction? And so that's certainly an area where BMA has been exploring intently about kind of the next phase of this, just given the importance of these social risk factors and designing and implementing effective interventions that address that.
Yeah, so I'm gonna give you guys a chance to make some news here if you want to. So, I think our partners and organizations that are part of Primary Care for America really believe in this concept of innovation in primary care as having longitudinal impact on health for individuals and populations. It's a belief we all share, but I think we also believe that innovation isn't limited to the partner you're working with, that as there's investments into primary care, the benefit of that enhanced capabilities is applicable to all payers. And really kind of thinking about this concept of using the two public programs to drive innovation, drive skill building, and kind of create a better healthcare system. And I would just kind of ask you to reflect upon that and kind of your observations as you engage with the two major public programs around innovation. Is it being spread? Are practices improving as you see these enhanced investments being made? Are capabilities improving?
I think they can. I think we're at the lead, but not the only in this space, whether it be Medicaid or value-based work or obviously for marginalized communities. I mean, what the work that FQHCs have done for decades was innovative at one point, and it continues to expand, and we've learned a lot. In fact, most of us within Cityblock come from the FQHCs and are seeking to be more innovative as we move into this different level of transformation. I think there's plenty of opportunity for growth and further innovation as we also take on more MA and dual eligible programs. So I'm hopeful. We're still, I think, really trying to prove our interventions are unique and scalable, and only time will tell.
Okay, great.
Yeah, I agree with that. I mean, I think, Medicare and Medicaid just are such important drivers of health system change, just given their scale and the populations they serve. We talked a little bit about, CMMI's important work there and supporting primary care, talked about, Medicare Advantage. I think a big thing is these partnerships are key. with diverse organizations and some of these, partnerships, like what's worked, what hasn't worked, what interventions have been shown to actually improve health outcomes and reduce costs, and how can those be applied in kind of other areas. And so that's really been kind of how we've been thinking about it at a high level. And then underneath that, there's, all these promising, programs and pilots, and so it's sort of like there's all this innovation out there, but how do you catalog it? How do you track it? And then like, what are the public policy implications? So what does a policymaker take from these, like all this innovation that's out there, and then incorporate it, within Medicare and Medicaid? And I know the administration and the agencies are thinking creatively about how to do these things. What levers can they pull, from a CMS perspective, in the Medicare Advantage space, looking at Medicare Advantage as a way to drive health equity. And we know that Medicare Advantage has been effective at reducing disparities and closing gaps of care, but, more needs to be done, clearly, as well. And so what aspects of the program levers can they employ to kind of further reduce disparities in care and close gaps in care, and looking at, Medicare quality, star ratings, and potentially adding measures there, looking carefully at, risk adjustment. And these things may seem, incremental and targeted, but, they do have an impact. And so certainly looking forward to working with, CMS and other policy in the policy community about, how we can be effective and really and close these gaps in care.
So 2 more questions. So the first one is where your 2 worlds overlap. So dual eligibles, it's been mentioned, but there is a increasing interplay between the Medicare and Medicaid programs with a number of beneficiaries. And when you think about your approach to innovation, particularly with the dual eligibles, you've spoken a lot about in-home care, but how are you approaching innovation with the dual eligibles, and what opportunities do you see with that population specifically?
Yeah, I think a great deal of what I've discussed is probably the most tantamount for the dual eligibles populations we serve, and that's the engagement piece. I think a great number of these patients are a bit, I hate to say it, as engaged as they are with the healthcare system, they're also disengaged because it tends not to be, unfortunately, a positive experience that a good number of these people have had. So part of where our innovation lies is to really listen to their needs, to try to tailor different care services for them, and to partner with other members of their care team. They come often with complex conditions and established relationships with providers that are often not connected for them. They need help in kind of navigating amongst their different providers at times, their different service providers, whether it's their DME or other pieces, and it is often quite difficult, I mean, for some of us to understand all of the pieces, let alone for them. So I think just the engagement of our case managers, our community health workers, just to help them draw the line between the dots is honestly where we're seeing really the difference, the impact that we're able to make. And I think that's innovative. Innovation, to me, is not so much always the big, bright, and shiny new approach. Sometimes it's literally just meeting a need in a different way.
Yeah, I think just, caring for the dual eligible population is just, one of those, enduring challenges for the healthcare system and policymakers. And, it's a vulnerable population, high healthcare needs. I think, historically it's been care that's, very fragmented for the dual eligible, not coordinated. In the Medicare Advantage space, it's really around bringing the MA model to that population, the care coordination, prevention, primary care via the DSNPs, dual eligible special needs plans, which is a type of Medicare Advantage plan. And I think, there's been success with these. I think the administration is looking forward for even further reforms around integration of these plans, enhancing consumer protections, and other steps that could even improve care further. But I think, this has been a difficult problem for policymakers for some time. How do you care for this population of 12 million people who have, healthcare needs, economic needs, and just the way our healthcare system is oriented, it impacts them worse than everyone else. But that's kind of one side of it. But also there's this tremendous opportunity to improve care for this population, given their healthcare needs, and using kind of these innovative care models that have proven to work. And so we're certainly encouraged by that, but definitely an important issue going forward.
Well, thank you both for that. So last question. Through good fortune, the CMS administrator and the director of CMMI have granted you 2 policy changes. So they were really good fortune, right? But 2 things. 2 policy changes that they have promised to make for you to make your innovative primary care models more successful. What are the 2 things you need to drive greater innovation in your models? I didn't
It's a
mean
good
to stump
question.
you.
I'm a bit stumped.
I'll take it, I guess.
Take it.
No, I mean, that's a great question. And just so appreciate the opportunity to be here today on this panel. From a public policy perspective, and coming from perspective of BMA, I think, there's been this tremendous growth in Medicare Advantage, that we've seen these improved patient outcomes, but people don't always make the link between like the success of the program and the public policy decisions that lead up to that. And so I think it's just so important to have this kind of a stability in the regulatory environment around public policies and payment policies. And, it's, in other words, it's no accident that Medicare Advantage has grown and flourished and is serving its population. It's really because of public policy decisions made by Congress and the administration. So certainly would want that, support for Medicare Advantage to continue. So that's number 1. Number 2, I think, health equity is such an important issue for this administration, for Medicare Advantage, for BMA, for our nation. And so really thinking creatively about how to kind of advance interventions that really close care gaps and reduce disparities. That's what we're talking about when we're talking about advancing health equity. And I think Medicare Advantage does have a track record of success, but clearly more needs to be done. So within the Medicare Advantage space, there are a number of kind of policy levers that the administration is contemplating, but we really think it's time to move forward with these and really lean into some of these interventions and to take action. And so certainly looking forward to working with the agencies and the administration and other policymakers, kind of how the best way to advance those goals. And it's, it's going to be difficult, it's hard work, it's detailed, and going through this kind of, notice and comment, I think is the appropriate way. So that way you get wide kind of stakeholder input and perspective. But that's what I would say. Those 2 things would be kind of a stable and predictable regulatory environment and really looking to kind of advance policies to reduce disparities in care.
No, actually, mine is probably a bit more tactical. Completely agree. But we are putting an awful lot of brain space right now to the efforts that we're going to need to carry through across multiple spaces once the public health emergency ends. Redeterminations in all of our markets, telemedicine, particularly in the medication-assisted therapy space. I think as a nation made so many advancements during this pandemic. I think just kind of cross-government, there needs to be some understanding that we need to continue in that direction. It's improved access. It does address equity. if we continue to have the ability to access virtual services and to take advantage of the many other changes that occurred in such an acute time frame, but why go backwards is the question. So a bit more tactical, but we are going to expend a significant amount of energy on our population once this comes to an end. And it just doesn't make sense that any of us in this space are going to need to go back. Why go back at this point?
Right.
And making those flexibilities permanent.
And that's what exactly what I mean. Making them
so we don't
permanent.
go backwards.
Yes, that's exactly what I mean.
Well, look, on behalf of Primary Care for America, I want to thank you both for joining us here today for a really robust conversation. Anything you're like, oh, I wish I would have said that before we go? Any final departing comments? You guys are good. Thank you so much. Really robust conversation. Really enjoyed it. Got our innovation conversation off to a good start. And as we transition, I'm going to introduce Joe Dunn from the National Community Health Center Association. And did I get that right? I did. Association of Community Health Centers. I knew I got the A in the wrong place. Sorry, Joe. And we're going to talk a lot. Joe's going to lead a conversation around innovations within community health centers. And after that panel, we're going to have a panel about innovations within the employer and commercial space. So, Joe, I would welcome you to come up and we'll transition.
Thank you, Shawn. Really appreciate that discussion and the last day or so. As we think about innovation at community health centers, we're joined by Sonia Bruton and then also Nancy Johnson. So I think maybe to start out, because there's such a wide variety of community health centers across the country, it would be helpful just to provide maybe a bit of a level set, or maybe paint the picture of your community health center right now and where you sit in the patient population. So Sonia, you want to start?
Sure, I'd be happy to begin. My federally qualified health center sits not far from here, down the road in Silver Spring, Maryland, is where we're headquartered, and we serve 2 counties in Maryland, Montgomery and Prince George's counties, 2 very different counties. We see about 78,400 patients a year through about 105 or so thousand visits, and we offer medical, dental, behavioral health. We also have the WIC program, and we do refugee health services in a pretty large way. We are growing, as many health centers are, as the needs continue to expand.
Hi, everybody. It's nice to be here today. I come from Tucson, Arizona, so I traveled a little bit further than Sonia today, but I'm the CEO at El Rio Santa Cruz Neighborhood Health Center. We were founded in 1970, so we're one of the older health centers in the nation. We take care of about 125,000 unique people in the urban area of Tucson, about 60 miles from the border of Mexico. We have about 250 primary care providers taking care of family medicine, pediatrics, internal medicine, dental care, behavioral health, both on the primary care side and the care of a lot of SMI patients. And as you all know, in community health centers, it's that one-stop shopping model. So our patients come in, they have all the disciplines available there for care, but also laboratory, filling all their scripts, imaging services, eligibility assistance with Medicare and Medicaid. And then I think it's noteworthy to identify the payer mix of our population. About 51% of our patients are on Medicaid. About 20% of our patients are commercially insured, 13% uninsured, the remainder falling into that Medicare space. So, in our urban area, we represent about 10% of the primary care delivered to our community. Thanks, Joe.
All right. I think, as I mentioned earlier in my intro, that one of the bedrock requirements of a community health center is the requirement around patient board, the locally driven majority patient boards. And I'm just curious, from your perspective, how does this kind of root your work in the community and allow for space for innovation? So, Nancy, do you want to start, and then we'll go to Sonia?
Yeah, so about 72% of our board members are patients of the health center. And so, we hear the needs of our community. Through that board voice, we do a lot of expanded work in our care for the homeless. We have a street medicine team that's out working. Through our board, we've also expanded a lot of our geriatric excellence and care for older adults. Most recently, through the pandemic, every month you've got a nice cohort of your patients present at your board meeting to give advice and counsel on your innovation, give you feedback on the services they've received. So I think that helps a lot. I think also we ask ourselves the question all the time, who's not at the table? Who are we not taking care of in our community? And I think that drives a lot of our innovation when we see services needed that are brought to us from board members.
For me, when we talk about innovation and we talk about the requirement to have majority of your board members be patients, for us, it kind of builds in accountability and integrity and forces innovation. Many people like to watch that television show Undercover Boss, and I like to say I live that, every day. At any moment, a boss of mine can come in and begin to interact at the granular level, the service level, with our staff, with our programs. So when we are looking at need and we're talking about experiences and we're looking at data, if it doesn't match what that person experienced when they were in the office, then none of that data matters. They want to talk about what they've seen and what they know. And so what that does, it kind of bakes in this level of integrity, checks and balance, and just ultimate accountability that keeps us constantly having to meet current, future need, and to plug any holes or any gaps that anyone sees at any given time.
Yeah. I can imagine that having the undercover boss situation is interesting. I think it's just the previous panel was talking about kind of the social drivers of care, and health centers have been doing this for a long time, kind of thinking outside the four walls. I think it was originally founded on the philosophy of health involves more than just health care. And so early health centers were providing digging wells or providing a bus transportation, obviously writing prescriptions for food, as we heard about from Dr. Chen. I'm just wondering, so in your health center, how does that commitment to those social drivers of health continue to provide or manifest itself for your patients right now? Sonia, you want to start?
Sure. We operate from a model of whole health, and so taking into account all of those factors is part of that. And every 2 weeks, I onboard a new crew of staff members, and in that onboarding process, we look at the tapes that show the beginnings of this movement, when the first health centers were started, what they looked like, what they included. So I'm always challenging those that are joining today that it's time for us to continue to evolve that model. It's not enough for us to take care of food, which we do. We provide boxes or those subscription services from farms where patients receive a box and it has fruits and vegetables. That's whatever is in season for that particular time coming directly to their homes. We don't assume they know what to do with those things that are in the boxes. So we make sure that we know the contents on any given week, and we put out YouTube cooking classes to make sure they know different things that they can do with the products that are in there, filled with medical education that tells them what it does and what it brings to their body and for their overall health and how it fits into their particular treatment plans. Back then, we've taken and we said, okay, well, there are prescriptions of things that are usually not part of what you would get from a doctor's office and would be part of your treatment plan. So we write prescriptions to parks in this DMV area. There is a wonderful, robust park system. And so we will have it integrated into our electronic health records, and we will write for them what park to go to and tell them what things to do there. And so kind of it remains baked in. When it comes to equity, there are all these images that show these people trying to look over a fence to watch a baseball game. And the one that I like the most was actually by an artist who put it out in 2015. And they have not just people standing on boxes, but they have those boxes standing at different levels. And the lowest level box also has the highest fence to try to see over. And it shows that the person has carved out a circle, and they're actually looking at the baseball game through the fence because that's the best that they can do. And that's the environment that we live in. There's a constant need to innovate, a constant need to have resilience and to have tenacity and to use whatever you have in front of you and take that to meet your needs. And so it's not even a choice that we can make. It's how we operate on every given day, and it's how we have to operate because we are not just responsible for completing visits. We're actually accountable at the board level, at the federal level, at the state level, at the county level, at the funders level, and we have many players within each of those boxes to actually deliver transformation for that particular person, whatever transformation that their particular need requires. So looking at the full spectrum of who they are and where they come from and what they have to work with is required to achieve those objectives.
Yeah, I love that imaging of the fences. Thank you. You know, I was thinking about that because we onboard every other week, just like you do, and we go back to the roots of the community health center movement and why are we here and how are we serving. And I think it's also noteworthy that our data is submitted transparently to so many entities about the care we're providing. So we don't have the luxury of not sharing how we're doing on COVID vaccines, flu shots, mammograms, early entry into prenatal care. All that data is just really apparent. One of the things we do to kind of add to the thinking about that is the data collection that our patients complete on entry into our system around social determinants of health and the Prepare tool we use to collect that data. Historically, we used to have to talk to our patients about that, but now it's just part of a kiosk system. And I think it's been really amazing to me how the data has changed when I don't have to verbalize that I'm fearful of losing my housing, or I don't have to verbalize that someone's beating me up, that I get to just touch the kiosk screen and how that data comes into the electronic health visit. So as the provider, I then have the opportunity to gracefully come into some hard conversations with people about what their current reality might look like and how do we help them with what their priority is. I like the earlier conversation from another panel member about addressing what that person is there for today, because we do a lot of work around their own self-management goals. It may not be getting their A1C under 9. It may be about, I want to get home safely and know my children are home safely, and how do we help make that happen for them? So I think that priority piece is important. Also in our system, we've built a team called Health Builders, and their primary goal is to improve the health of our patient population and also to improve the health of our employees. We have about 1,700 employees, and we're a self-funded company. So, you know, keeping them as healthy and tuned up as possible is important as well. But that Health Builder team offers everything from mindfulness to Tai Chi to weight loss to our pediatric or childhood obesity program, the MEND program, so that we're able to help families and help children and families, obviously longitudinally, hopefully to become healthier adults in line with what their community has to offer for them too. So a lot of that work is really community-based. The other thing we've built around social determinants of health is a closed-loop referral system, so that within our system, if I have someone with food, even though we have food boxes in the health center, I may put a referral into the community food bank, which then loops around and comes back to us once that need is met. Because we have so many community partners, and I don't know if they're stable or if they're writing grants to make next week's payroll. So that closed loop referral allows us to know, yes, we got them rent assistance, they're not going to be evicted, or yes, we figured out a better transportation for them to get to the specialist, or yes, we're sending a navigator to go to the oncology appointment. So that closed loop referral in our EHR has been really an instrumental help to improve care.
That's great. I love that. lifting up the need for partnerships at the local level, really to understand, where you can have leverage to really.
I just don't want to be in the housing business.
Right. There's you have so many other things going on right now. Just earlier we had a discussion around workforce, and it's hard to have any conversation in healthcare right now without talking about the workforce challenges. Just by background, NAC did a recent survey of health centers, and we saw that nearly 70% of health centers lost between 5 and 25% of their workforce over the last 6 months. And, a big piece of that was the ongoing stress of the pandemic, and obviously, the kind of increased salaries that we're seeing. As we think of short-term, long-term, medium-term solutions, there's a lot that has to happen. I'm just curious, how is that playing out for you and your local community, and ways and strategies that you're thinking about, dealing with it right now. So, Nancy, you want to start, and then go to Sonia?
Yeah, Sonia and I were actually talking about this over lunch a little bit too, just about some of the frontline staff, and particularly many parents who needed to stay home with their children during the pandemic, take care of loved ones. I would be out rounding. We have 13 different sites. I'd be out rounding. And it was amazing to me how many days when I would say, "How are you?" and the response would be about a sick family member or the loss of a family member to COVID and other complications. So I was amazed that we had so many employees that were at work with all the things going on in their lives. We lately have been really struggling with frontline, with medical assistants, licensed practical nurses, primarily. Those have been our two areas. And we also have been doing well on hiring registered nurses, which worries me because many of them are coming from tertiary care and saying, "I can't do that anymore. I want to work in community." So I feel like kind of community poaching around that. But we've done a lot of workforce development, and we have a lot of strategies in place, and that we really believe in growing our own. So we serve as a tri-county regional AHEC, Area Health Education Center. So that gives us federal and state grant dollars to work on the pipeline. We start off building the health club, health career clubs, host the clubs in the high schools, in our urban and the rural communities. So we're starting the pipeline there with scholarships to get kids into Med Start in the summer, other immersion sort of experiences that are interested in healthcare. We also coordinate a lot of clinical rotations across discipline for medical students, nursing students, physical therapy, pharmacy, MPH, into our environments. And then we also are a continuing education arm. So we have a lot of opportunities to try to recruit and retain workforce there. We're a teaching health center. We do have AT Stills medical students on our campuses. We have a family medicine residency. And, the residents are closer to practice. I find the medical students are a little too far away. As you heard from an earlier panelist, they love every rotation they're in. And so our chances of capturing them into our workforce, particularly with debt, is challenging. But the residents more likely. We have a nurse practitioner residency program, so newly minted nurse practitioners can apply to our residency to do a 12-month residency right out of practice, giving them exposure to complicated patients, working side by side with experienced clinicians. And we train them for ourselves, and we train 2 of the cohorts to go out to rural community health centers. So we're also working on populating and helping the rural communities. Also along workforce, we work tightly with the community college. Right now, we're starting a cohort of 14 frontline employees who will become certified medical assistants. So they'll go through that 2-semester program, become certified, and they have a commitment to work for us for 2 years. So, a lot of growth in that way. We also do a lot around retention, Joe, around going back to the Institute of Medicine's Joy in the Workplace work. And how do we address the challenges of working with patients that not only have a lot of chronic disease and a lot of challenges, but also have community challenges, and keep our staff from burning out? So we've been doing a lot of things around planned leave, dedicated time, not seeing patients, and trying to build roles that not only have clinical practice, but also give people the opportunity for academic and research opportunities when we can build community-based research. I think the last thing I'd add, and then I'll stop talking, I promise. The last thing I would add is that we recently acquired an academic practice. And my main strategy was to have access to 24 family medicine residents with us for 3 years, hoping I can increase the pipeline of recruiting and hiring them. So I think that the residency is probably the best, and then in terms of growing all our other levels of staff, creating good job strategies so they kind of see their career through our eyes.
At CCI Health Services, my federally qualified health center, our patient population is about 70% Latino, 14% Black, 3% Asian, 5% white. And my staff mirrors those demographics, with skewed a little bit more toward Latino. And so for us, in terms of our workforce, we have a big draw in that people are able to care for those who look like them, but also the ability to work all day in your native language is a very powerful recruitment tool and a powerful retention tool. And so we'll have nurses and medical assistants and dental assistants who most of our patient population was not born in this country. They have come to this country. Similar with my workforce. And so for many of them, English is not their first language. And so taking the knowledge that they've gotten in school and being able to then apply it all day in the language that's most comfortable to them, to the population they most understand, is pretty powerful. What threatens that for us is in this area, we have lots of major hospital systems and private practices who know that if the person has worked for us, that they are first and foremost versed in high quality care. They know the evidence-based practice interventions to bring to bear. They are able to work with all populations. They are used to and ready and want to work hard. They're committed to making a difference. And so we almost become the job pipeline for the other major medical systems because they're also will take a chance on somebody when they're an early career professional and will take them right out of school. And the other hospital systems know that. And so they'll let them work for us for about 5-6 years or so. And then they just pluck. And we're happy for our staff members who will be able to earn salaries that we cannot pay them and that have career progressions that we cannot offer. So it's a double-edged sword. We are part of our mission. We're a learning institution similar to you in El Rio. We have a planning grant right now to have our own teaching health center. And what I can tell you is that taking that on is hard work and it's hard to find the partnerships, but we're committed to doing it partly on behalf, as everything else that we do, of our patient population and our staff, owning our own, controlling it and shaping it and making it what we need or what we want to see in the world is critically important to us. And we don't take that lightly. So we're taking on and we're doing the hard work. You know, those who are, we find that people get really excited when you start talking about putting together and having a community-owned residency program, but then there's not the help or the partnerships or the workers to help stand it up and to make it happen. So some of our challenges are around the burnout. We have worked every day in this pandemic and we have worked inside offering in-person care the entire time. Throughout the entire pandemic, our telehealth population and service provision never reached above 6%. We were much more like the school systems and that our households broke down when it came to trying to handle things other than living within their households. In the areas that I serve, it's not uncommon to have a 3-bedroom apartment house 3 to 5 families. Sometimes you'll have the master bedroom. We'll just have a line down the middle and 2 different families will share that space. And so being at home and trying to have healthcare administered from home is not only not feasible, but it's not desired. We also had and saw a great deal of dominance within the households where we'll have a male person in that house that controls everything, whether the internet gets turned on and can be used by everybody in the household, whether you can have a private conversation. And so what we learned is that our medical facilities were actually safe spaces, and people needed them and used them as such. And so we have a work environment that has all of those nuances baked in it, and that runs folks down. We are playing with 4-day work weeks, and not in the typical medical model where it's 10-hour days for 4 days and then a day off, but the true 4-day work week model that has you do deep work and work fully for 4 days and then have 3 consecutive days off where they're actually off. And providing that to a clinician and convincing them that it can be so is a difficult sell in some ways. But we're playing with that. The Teaching Health Center, once we launch it, 2 years is what we have to get that going, will help with our pipeline for clinicians. And then the others, it's really around increasing our pay levels such that that $1 or $2, and that's usually all it's taking per hour for other systems to pull from us so that we can retain them, so that they can continue to do the work that they want and also build their life and their households and advance their careers.
Really appreciate that. It seems like, what you talked about, obviously federal investment around teaching health centers. And we know, we heard earlier that, that program has a cliff next year and that needs continued funding. And so to think about starting it up with funding expiring, that would be daunting, right? And so, but then there's the career laddering, to show people that they have a career in the future there and they can move up. And then there's the grow your own, right? To tap into the community, and that may be.
Also,
Yeah.
I think also when you talk about the teaching health centers, the other piece about that funding, it does not get you to a break even on providing that. You mentioned about all the partnerships and the people you engage. Our investment in teaching health center has required us to underwrite the additional expenses for that. And I think that's part of the challenge in developing the residency programs across discipline, whether there are PharmD residency, RNP, whatever residency programs we're working on, is that the grant funding doesn't cover the full cost. So, how do we improve and advocate for that as well, I think.
Yeah, I appreciate that. And what we're finding also, you heard earlier that they're only in 26 states. And so for me in the state of Maryland, we'll be the first community-owned residency program. And so the infrastructure is not in place for it. The state allows payments from the state to hospitals to administer residency programs, and it specifically says hospitals, and so we have to get that changed if we want to see any of those dollars. We don't have the relationships and the trail blazed, and so something that's been around for a long time, our health center has been around for 50 years, for example. This program has been around for a while, but it's new in our state and in our markets, and so it's almost as though you're starting from scratch, as though it never existed anywhere else.
Yeah, maybe transitioning for a second. So we obviously know that access to high quality primary care ensures effective chronic disease management and prevents hospitalizations and prevents more severe conditions. So just curious, what are some of the programs that you're seeing that maybe allow you to see around the edge? Sonia, I would love to hear. We were talking a little bit about a program that you have around prenatal care and the importance of that. So it's an innovation that you're working on right now?
Mm-hmm. The majority of our patients are in those childbearing years, 18 to 40, 45. And so we do quite a bit in women's health, but also quite a bit in prenatal, and making sure that we start the interventions of whole health from the very beginning, from inception to delivery, and then care for them after that. And so we do employ the centering pregnancy and centering parenting models. We have found both in terms of concrete data and anecdotally that having those shared or group visits around gestation and around prenatal and around delivery is huge. We are a huge integrator of our WIC services into our primary care, and so chest feeding is a huge part of what we teach and what we promote, so much so that as we've gone through as a country this latest baby formula shortage, and I guess it's actually global and not even just in our country, it hasn't hit my population as much. 90% of our delivering patients chest feed upon delivery. We teach it as they are going through their prenatal care. We embed breastfeeding peer counselor in the hospital, so that when they deliver, that's one of the first visitors that they have, and they're working with them and working with the baby right there and then before they even go home, and then support continues after that. We make sure that we have our Reach Out and Read program, that it begins not after the baby comes, but also during that prenatal period. And we begin to talk about the importance of reading, and we know that the difference that makes alone in terms of somebody's health and as one of those social determinants of health. And so for us, it's taking the needs of that population, caring for their bodies, of course, but also recognizing that there's a mental health component to when you're carrying and when you deliver, and what might happen biochemically to your body after you deliver. So we have our behavioral health specialists and consultants who are part of that prenatal education process, and so that they get seen by the dentist, they get seen by the therapist, they get seen by all of our additional services, the nutritionists and all those folks, so that when they deliver, all of those needs have been provided for and ramped up, and they're aware to be aware of them and to watch out for them.
That's great. I know we also are a centering shop too. And we have an integrated model between OBGYN physicians and certified nurse midwives. So they also do home visits after the birth. And we also have a lactation educator, which has been fabulous. I really have been pleased. We've only had her for a couple of years. So I guess I'll go to the other continuum, the other end of the life cycle. We'll talk about some of the work that we do with older adults. So we have our team-based model, as I mentioned before, is interdisciplinary, but we've started adding other specialists and disciplines to that model just based on the needs of our older adults. So, some of our patients who are very fragile, who we try to minimize readmissions and hospitalizations and skilled nursing stays and things like that. So we've added physical therapy to our scope of service. We started looking across our system, and we were generating about 125 referrals for some type of therapy weekly, and not being able to get access to care for our patients. So we just employed them. And for the physical therapists, this is great because now we have other team members laying their eyes upon some of our most high-risk patients more frequently, and having the ability to work on strength training, of course, in our older adult population. So physical therapy has been a hit in terms of chronic disease management for us. But I really liked our very first physical therapist told me that in all her years of practice, she'd always been an outpatient provider. And she said it was just amazing to her to see a patient and be able to have full look into that patient's record, to be able to say, looks like you're overdue for your mammogram, looks like you haven't had a flu shot. And in all her years as a physical therapist, she never had vision into those other pieces of care. So it was just a really clear illustration of what having an integrated record can do, and not having to work around the traditional healthcare system to hunt for data, whether it's lab results, colonoscopies, or whatever it might be. So, adding that team member has been really important. Our RN care coordination team is both centralized and decentralized. At the centralized level, every day they're pulling from the HIE all of our patients who've been admitted or discharged, so that phone calls can be made to say, how are you doing at home with your newborn? Do you have your follow-up appointment? Do you have your walker? Is someone home? Food in the fridge? Do you need us to deliver your meds, and going over med reconciliation? So that centralized piece. And then each of the locations have a team of RN care coordinators who manage a panel of high-risk patients in concert with the provider, so that they can do the chronic care visits and bill Medicare for those, so they can anticipate gaps in care and try to avoid unnecessary use of tertiary care. So those folks. And then there's a 24/7 telephone care team that takes all the calls from our patients, whatever their needs may be, whether it be questions around education, how do I get into the portal, how do I need a virtual visit. So I think for us, the investment in those other disciplines on our team has been really helpful. We've been really fortunate to be able to hire some psychiatry, geriatric psychiatrists. We just also started a child psychiatrist. so that our pediatricians, our adult providers have access to do a warm handoff when people are willing to have that intervention, when people are in our sight and they don't escape before we have to track them down, but we're able to build those pathways around care. So I think the question around innovation for us now is, should I hire some more folks that are specialists? How much of that specialty pathway of care should we try to manage the best we can? We have, for example, we have a part-time pulmonologist now. All of our COPD, our respiratory patients, get worked up there if need be. And that, internal piece into our system has been very useful for us as well.
Yeah. So maybe last question. It's hard to have a conversation around innovation without thinking about the COVID element to this, right? And how everybody had to kind of transition quickly. Obviously, telehealth is a piece of that, but obviously we've also seen an increase in the mental health and needs across the country. And because of isolation, health centers have had the physical health side with providing vaccinations and testing. But I'm just curious, around the behavioral health needs that you've seen since both of you are providing integrated behavioral health. So Nancy, maybe you start and then Sonia.
Yeah, and our entree into behavioral health was probably about 12 years ago, with just simply attaching a licensed counselor to each of our primary care teams. So the warm handoff I mentioned earlier, it could happen easily. I'm finishing a visit with a patient who suddenly says, oh, by the way, I just learned my mother's been diagnosed with Alzheimer's. I don't know how we're going to deal with this. And my ability to say, let me introduce you to Jim. He's part of my team. He can probably help you figure out some coping mechanisms, help you kind of plan what resources are available. So we've always done that in screening for depression. But about 4 years ago, we started really building what we call specialty behavioral health with our therapists, our psychiatrists, our intake case managers, our substance abuse treatment program. We do Suboxone and Vivitrol, and are also starting to do intakes in the home for that population. And the demand, every day our behavioral health team huddles in the morning just to triage the calls that come in from discharging hospitals to establish behavioral health care for our patients. Some of our managed care organizations in the Medicaid space have now started really looking at, okay, you're taking care of this Medicaid member on the primary care, but they're getting their behavioral health out here. Does that make sense? Patient choice, of course. But in communicating, you can now get your psychiatrist and your therapy where you're getting your primary care has been a real winner for members. Once again, allowing that care to be highly synchronized and highly integrated for them. The demand is still more than we can. Back to your workforce question, we've been fairly successful with psychiatry. Therapists are where we're really having challenges in recruiting. But, the demand in our community is high for all patients, self-pay patients, people with commercial insurance, everyone.
Well, I'm a licensed clinical psychologist, so we have mental health and behavioral health baked throughout the entire organization. We are a trauma-informed practice. From the time somebody comes in the door, we are making sure that they are physically safe and they are psychologically safe. We're paying attention to the words that we use. We look at our delivery of service and believe that there's some component that operates in all of it. In COVID, there have been some additional demands, and so I actually do neuropsychological and psychoeducational testing because so many of our students are behind or experiencing learning challenges, or things are happening and school systems and teachers and parents and families don't know what to do and don't know what's going on. Is it cognitive? Is it emotional? Is it a combination? Somebody needs to know what to do next. We are a huge provider of service in the refugee health program and have been, and we have had a 127% increase, 2,000 more patients of Afghanis who are here in this country through that program. And so the demand of that has meant I have started to do the intakes so that we can find out from the referrals from that population. And as an organization, we've had to add our depth of service around trauma-based disorders. So we now offer eye movement desensitization and reprocessing EMDR treatment because it's evidence-based to really go for those that have deeply rooted and seated PTSD, because that's what we're finding. We have a large degree of our population who come to this country non-assisted through a program, but through their own means. And that journey and what they face once they get here is filled with pretty intense trauma. So we've always had a lot of trauma in our population, but it has really significantly increased as the violence at home has ratcheted up and in neighborhoods, and as the folks that were doing okay before, 2 years into this, the answer to how are you doing or what's going on is, I'm not okay. And that's at all levels. That's not even people just living on the margin. A lot of folks are not okay. And so we assume that there's some degree of breakdown, may not be to diagnosis level, but in psychology, we say anything that impacts your ability to love and to work and to play effectively might need to be addressed in some way. And in the people that we're seeing, there's some degree of breakdown in their ability to love, work, play, and exist effectively.
Yeah. Well, thank you so much for your contributions to this broader conversation around primary care and innovation. So I think we're going to transition now to a panel around the employer market. And I should have brought my program to introduce the panel. But thank you very much, and I look forward to hearing the rest of the conversation today.
Thank you.
Thank you.